Good evening, ladies and gentlemen. Welcome back to the Recovery Bank Community Education Series. My name is Frank Bollock. I'm the Recovery Bank Project Manager. The Recovery Bank is a community recovery resource center. We're located at 120 Wyoming Avenue in Scranton. You can check out our schedule of events and activities at www.recoverybank.org. Our basic mission here at the Recovery Bank is to connect peers who are new to recovery with peers in recovery with some success. We also look to connect recovering peers with recovery resources. Same thing for family members of recovering persons. We look to connect and help those family members to connect with resources. And also to provide some educational opportunities for the community in general. Our hope with this, our education series, is that we will be able to continue it on Thursday evenings at 6 p.m. We present to a limited live audience here at the Recovery Bank because of COVID, and our effort is to publish the programs on Zoom or Facebook Live. I understand we're having some technical difficulties tonight with Facebook Live, but we are recording this evening's program, and we will be playing it back on either our webpage or our YouTube page. Our hope is to, as I say, to continue with our programming 6 p.m. on Thursdays. Next week on the 15th of April, Dr. Karen Arscott from Geisinger Marworth, an addiction medicine specialist, will talk about multiple pathways to recovery and the brain disease of addiction. On April 22nd, Barbara Durkin, the executive director of the Lackawanna Susquehanna Drug and Alcohol Commission, will present on the opportunities to access treatment through her offices. And then on April 29th, Vince Carolyn, who's been a leader in the treatment community for well over 40 years, will talk about intervention techniques for family members. Tonight, our special guest is Dr. Thomas Smith. Dr. Thomas Smith is a clinical psychologist with over 40 years of experience. Dr. Smith is a graduate of Marywood University and the Philadelphia College of Osteopathic Medicine. He has a fabulous resume that's multiple pages long. Our program is only an hour long, so I can't go through the whole thing, Doc. But he had been the director of the Counseling Center at the University of Scranton for many years, retired last year, remains an adjunct professor at the University of Scranton, at the Geisinger Commonwealth Medical College, at Philadelphia College of Osteopathic Medicine, and lots of other credentials. He is a member of the Treatment Court Advocacy Center of Lackawanna County. He's also a member of the Treatment Court team, and just a fabulous asset for us here at the Recovery Bank. Dr. Smith is going to speak tonight regarding anxiety and mood disorders and some interweaving of co-occurring disorders. Without any further ado, I'll introduce Dr. Thomas Smith. Thanks.
Thank you, Attorney. Good evening, folks. What we'll do for the next 45 minutes to an hour is, again, talk about several facets. The core theme of all this is the importance of appreciating co-occurring disorders, its complexities, and how we need to approach them in a delicate and thorough fashion. What I'll attempt to do at first is to give a brief overview of the DSM-5 standards to meet diagnostic criterion for substance-related disorders. Then I'll move into mood disorders. Then we'll move further into anxiety disorders. After that, we'll try to weave it together and again see its complexity and its need to be in a treatment format, extremely thorough and repetitive in how you approach the individuals in therapy. By repetitive, I mean, to use an adage from when I used to work inpatient psychiatric care, that treatment planning begins the first day the person's admitted to a unit. That would include both substance abuse and or mental health. In the arena of choosing treatment programs or therapy models that meet the needs of a co-occurring condition, I'll briefly at the end of this presentation review a model called cognitive therapy that Aaron Beck really took to a new level in the 1960s, and has continued to evolve. And many practitioners, notably one that actually runs the Center for Cognitive Therapy at the University of Pennsylvania, Corey Newman, is well known and authored many books related to substance abuse and a number of individuals in their center and at the Beck Institute for Cognitive Therapy and Research out on City Ave in Philadelphia are well noted for their due diligence and research in the area of co-occurring disorders. So, let's proceed.
Doctor, can you speak up just a little bit, please?
Sure. The first condition we'll address tonight is some of the basic standards related to substance-related disorders. As we know, these disorders are related to the taking of drugs and alcohol. The side effects of these conditions, such as taking medications and being exposed to different toxins, certainly can exacerbate these kind of conditions. Under substance use disorders, substance dependency is a substance that takes maladaptive and frequently enough to produce clinically important distress and impaired functioning as well as behavior characteristics. It is found in conditions with all classes of drugs except caffeine. Tolerance is one of the significant indicators that leads the person to a diagnostic conclusion of substance dependency. Tolerance indicates that a substance has been used long enough for user's body to grow accustomed to the chemical effects. Therefore, a greater quantity of substance is needed to produce the effects, especially apparent with alcohol, opiates, and sedatives. One note to be made there. It tends to be interesting that when people reach a certain tolerance level, a chronicity of abusive substances, let's say alcohol, they reach a peak where there's a regressive moment where along their lifespan of abuse of the drug, that it actually, the tolerance reverses itself, where it only takes a little bit to replace and put the person back into an intoxicated state. So it's kind of like a bell-shaped curve. A growing level of tolerance builds over the years, and then at a certain point, you see the bell-shaped curve go down the other side, where it takes less and less to achieve the same effects it did in the earlier stages of the person's dependencies and abuse. The other clarification is, along with substance dependency, is substance abuse. Now, this is a residual category for patients who do not meet criterion for substance dependency, but it applies to all substances except nicotine and caffeine. Substance abuse doesn't mean that the person is not experiencing difficulty with their lifestyle and the use of, say, alcohol, but at the same time, the substance abuse has its own devastating effects and certainly can be, again, a definite warning sign that leads the person to a state of substance dependency. Different types of substance-induced disorders that we take a look at is obviously substance intoxication. Also, under the conditions of substance abuse, we see substance withdrawal, which is a collection of symptoms that develop when a patient who has frequently used substances discontinues or markedly reduces the amount used. All substances except cannabis, caffeine, and PCP, hallucinogens and inhalants, have an officially recognized withdrawal pattern. I'll say that again. All substances except cannabis, caffeine, PCP, hallucinogens, and inhalants have an officially recognized withdrawal symptom pattern. For each category of substance abuse, there are certain guidelines and diagnostic conditions that should be applied. In other words, although you may see people in an inpatient facility or an outpatient facility receiving similar treatment for their different drug abuse and or alcohol abuse, you still have to be able to recognize individual unique characteristics that make each one of those conditions also important to be able to diagnostically separate and treat accordingly. So along with the split of substance use disorders into dependency and abuse, we also have what we call the induced disorders. And just briefly to identify them, and this covers drug and alcohol and mental health conditions. We have induced disorders with intoxication, withdrawal, intoxicant delirium, withdrawal delirium, induced persistent dementia, induced persistent amnesic disorder, induced psychotic disorder with delusions, induced psychotic disorders with hallucinations, induced mood disorders, induced anxiety disorders, induced sexual dysfunctions, sleep disorders. The reason I list them is to give you a brief overview of symptomatically one of the complex features in treating co-occurring disorders is that symptoms from either anxiety or mood disorders can certainly mimic certain characteristics of substance abuse disorders. Likely, certain characteristics of abuse of, say, amphetamines can have a mimicking effect under a mental health diagnosis called bipolar disorder in its subcategory of what we call manic episodes. So, again, the reason I stated before that, excuse me, cheers, that we need to be so attuned to our diagnostic assessment, treatment planning, and ongoing, and I underline this word, which is probably the most important word for tonight, ongoing treatment planning and modifications during the lifetime of care that that person is receiving, is to recognize that, for example, characteristics like amphetamine abuse can provide what might be seen as a symptom or symptoms of manic behavior, but in reality, it may be symptom characteristics of certain drug abuse behaviors. Okay. Another, again, diagnostic category that we're going to review here for a second, are the anxiety disorders. And I'll just provide a general definition of panic attacks. A panic attack is a symptom characteristic that includes characteristics of anxiety, obviously. It is not in and of itself a diagnosis. Panic disorder, as I'll get to in a few minutes, is in and of itself can be a diagnosis, but panic attack is the some categories of anxiety characteristics that build as a building block to certain diagnostic conditions under anxiety disorders. So, panic attack is a discrete period in which there is the sudden onset of intense apprehension, fearfulness, or terror, which often is associated with feelings of impending doom. Shortness of breath, palpitations, chest pain, discomfort, choking, fear of going crazy, or losing control are present. Many people appear in emergency rooms believing that they're experiencing a heart attack, and what they're actually experiencing is a panic attack. One of the first categories, diagnostic categories under anxiety disorders, is agoraphobia, which is anxiety about or avoidance of places or situations from which escape might be difficult or embarrassing, or in which help may not be available in the event of having a panic attack. So, agoraphobia, obviously one of its main clinical hurdles is its tendency to avoid and hide. In the world of therapy designs, in the mental health world, we try to use exposure on different levels to slowly challenge the cognitive fears and avoidant behaviors that help maintain the agoraphobic condition. Another diagnostic condition is panic disorder with agoraphobia. I've already read both of them, so I'm not going to reread this again, because basically panic disorder are the characteristics I read under panic attacks, and agoraphobia I just reviewed. So there can be certain conditions where there are people that experience panic disorder with agoraphobia. The 1-2 punch there is the panic disorder helps reinforce the feared characteristics experienced with agoraphobic conditions. Another condition is panic disorder without agoraphobia. We get pretty classy in the field of psychiatry and psychology. But anyway, so it speaks to itself that agoraphobia can stand on its own as a diagnostic condition, as we see, and that panic disorder does not always have to be paired up with agoraphobia, but panic disorder, again, can stand on its own as its own diagnostic condition. And again, the summation of these conditions are agoraphobia without a history of panic disorder. The reasons these are important to break down is as we get to understand these conditions as time moves on, is that each one of these would require certain treatment approaches that meet the specific needs of each one of these subclinical conditions. For example, possibly with agoraphobia, you certainly would use some of the characteristics and treatment approaches identified in cognitive therapy, but you would certainly go after agoraphobia with treatment approaches designed under the model called behavior therapy, especially in treating the avoidant characteristics and using exposure, which is a behavioral treatment model, and addressing those fears. Another type of diagnostic condition that we identify in the anxiety disorder area is specific phobias. Formerly, it was entitled simple phobias. And the essential feature here is marked and persistent fear of clearly discernible circumstances, objects, or situations. Exposure to the phobic stimulus almost invariably provides some type of immediate anxiety response. Specific types of phobias, and there are many of them out there, are animal types of phobias, natural environmental types, blood injection injury types, which are, for specific reasons, one of the most difficult to treat, and situational types. As I take the time to review all these different diagnostic areas, you can see in and of itself, and you'll see the same thing in the substance abuse categories also, that there are many different types of anxiety disorders, many different types and features related to the substance abuse disorders, and the same for the mood disorders. That's complicated enough. When you add all three of these, and I guess it's a 1, 2, 3 punch, together, you can appreciate the importance when an individual comes to treatment. It could take you several months to really truly appreciate the enormity of the diagnostic picture and how profound and impactful it can be in a person's life. Now, tonight, I'm just going over 3 variables. I will not even be addressing, but it's something very important to realize, that diagnostic conditions can occur in early childhood. So, along with any of these conditions I'm addressing tonight, it is quite common to see a number of folks presenting for treatment that may have an attention deficit hyperactive condition. They may have different learning disabilities. They may have meet the criterion for moderate or mild mental retardation, or other types of cognitive declines. I mean, in the medical arena, given, especially with the substance abuse conditions, how they impact a person's life or the lifestyle that the person leads while they're actively abusing or using, introduces a number of different neurological, medical conditions that are also offering its complexities to how you need to be extremely sensitive and thorough, and again, like I said, repetitive in reviewing your treatment plans and your goals continuously throughout the course of treatment. Another diagnostic category under the anxiety disorders is social phobia. Previously called social anxiety disorder. Its essential feature is pretty obviously. It's a marked and persistent fear of social or performance situations in which the person may feel embarrassed in their presentations. You can see this just in social gatherings, or a person who may be preparing for a speech tonight. But thank God for my Irish genes, because it totally denied accessibility of social phobia and fear in being a ham in social settings. So that's one I'll never have to worry about. Another condition that we certainly hear quite often that falls under the anxiety disorder area is obsessive compulsive disorder. And the essential features are recurrent obsessions or compulsions that are severe enough to be time-consuming or cause marked distress or significant impairment. And a specifier, and I'm not going to get into this, but each one of these diagnoses has about 5 or 6 pages to it. And they have all these special characteristics related to them. And one is they call specifiers. And one of the specifiers under OCD is that, and it's baffling, but it's not only limited to OCD, but they display an enormous amount of poor insight into the condition. And again, that's where something like cognitive therapy would be a way of approaching the cognitive constructs that the person operates out of that neutralizes their ability of objectivity and being able to have the insight to really address OCD. As a clinician, when I see a lot of insight or a lot of lack of insight, I also am sensitive to their motivation. And some folks will say, gee, this person just isn't motivated. Yeah, it's not so that they're not. And that always has a negative pejorative effect on people. Well, it may not be that they don't have a lot of insight. They just don't get it. They don't get it. And if you don't get it, how the hell can you be all that motivated? Do you know what I mean? So it's like again, the time and patience that a practitioner needs to practice and appreciate. In the old psychoanalytical terms, we used to call it counter-transference. We need to be highly sensitive to how a patient or client, or just human being, enters into treatment and how significant their lifestyle and struggles can impact you as a practitioner. Counter-transference can also apply to liked experiences that the client had that you as a practitioner, maybe in your own personal life, has had, and appreciate how that can affect your own insight and your own, do you get it as a practitioner, and truly trying to understand where the client is at, the struggles they're experiencing, and the supports that are going to need to be in place. And, patience is a virtue, seldom found in women, but us guys don't seem to have a hell of a lot of it. Yeah, that's modified, saying. But we truly need that gift of patience and understanding to sit with people that struggle with such a complex picture. Just a couple of more diagnostic areas under the anxiety disorders is PTSD. And I'll just read a brief couple of sentences about PTSD. And obviously most of us have an appreciation for it. PTSD is an essential feature, is the development of characteristic symptoms following exposure to an extreme traumatic stressor involving direct personal experience of an event that involves actual or threatened death or serious injury or other threats to one's physical integrity, or witnessing an event that involves death, injury, or threat to the physical integrity of another person, or learning about unexpected or violent death, serious harm, or threat of death or injury experienced by a family member or other close associate. Symptoms must be present for more than 1 month to meet the diagnostic criterion for PTSD. And under specifiers, as I talked about before, you can have an acute, chronic, or with delayed onset types of PTSD. The reason they mark a 1 month plus on one of the criterion that needs to be met to give the diagnosis of PTSD is to be able to identify what we call an acute distress disorder, which usually has a lifetime of several weeks and then in and of itself starts to ameliorate. So we have the acute distress disorder, same as PT, but again, generally lasts only about a month or so, okay? And the time frame is the major characteristic. This is what sometimes also happens. Although it seems like symptomatically there's a sense of relief and resolution after a month or so with the acute distress disorder, that doesn't mean therapy's over with. That means just the natural characteristics, just like some medical conditions. A person could have a severe medical condition that only lasts a certain period of time. It resolves itself, but that doesn't mean that there's still not needs that the person have secondary to something like the acute distress disorder. The therapy certainly could still be, or a type of supportive therapy like a group therapy that could be beneficial to the person. Another diagnostic feature is generalized anxiety disorder. Generalized anxiety disorder has essential features, is related to excessive anxiety and worry occurring more days than not for a period of at least 6 months about a number of events or activities difficult to control and having difficulty to control their worrying. So again, all the general symptom patterns of anxiety bunched up into what we call generalized anxiety disorder. But a significant feature is occurring more days than not for a period of at least 6 months. That time frame to meet the diagnostic criterion is essential under this one. And the last, well, there's two, and I'll just do them briefly, but this expands the complexity of co-occurring disorders. We have anxiety disorders due to general medical conditions. The essential feature here is significant anxiety that is judged to be due to the direct physiological effects of general medical conditions. Must be evident from the history and examination using lab findings and indicating its current medical condition. Specifiers, it can occur with generalized anxiety, panic attack, or OCD. So, here, if you just want to throw more fuel on the fire, depression, anxiety, substance abuse, chronic history of lifestyles with substance abuse, and any of the other conditions, and let's just throw on a couple of medical conditions just to, enrich the pot. Other condition, and the last one for this category is, again, substance-induced anxiety disorders. The essential feature here is a prominent anxiety symptom pattern that are judged to be due to the direct physiological effects of substances. And the specifiers can be with generalized anxiety, panic, OCD, phobia, with onset during intoxication or with onset during withdrawal. The withdrawal could be over with, the intoxication's over with, but the anxiety certainly can be lingering for quite a while. So, that certainly is something that needs to be identified. And as I'm rambling around here, here's my little marker. All right, enough of that. I'll now just briefly review the mood disorders. Then we'll go into the co-occurring conditions. And as this is marked to be about 7 o'clock when we wrap up, I'll probably have just a few minutes to address some of the important reasons why I think, and not certainly the only one, but certainly a very important treatment model, cognitive therapy, is certainly effective with any one of these diagnostic categories standing on their own, but also highly effective in co-occurring conditions. Then at the end, I'll mention briefly personality disorders and how they are an essential player under conditions like this, but a number of times doesn't get the time and attention they need. Mood disorders. Mood episodes are defined as major depressive episodes. Now, under major depressive episodes, now what I'm going over for these four, depressive episodes, manic episodes, mixed episodes, or hypomanic episodes, these are just symptom clusters. They're not the diagnosis. Then I'll address the diagnosis. Then, like I said, we're going hopscotch over to talking a little bit about some stats and and how these three together, again, obviously complicate the picture. So, under major depressive episode, we need to have 2 weeks of depressive mood or loss of interest, accompanied by at least 4 additional symptoms. The 4 additional symptoms could be sleep appetite disturbance, it could be anhedonia, it could be motivation, could be cognitive decline, a number of them that are there. Manic episodes, a distinct period of abnormal or persistent elevated, expansive, or irritable mood. And I'll just highlight one thing. When we think of mania, we think of that broad, expansive, euphoric kind of characteristics. Well, sometimes a person who presents in the earlier stages of therapy, because we certainly need manic and depressive features to come to a diagnostic conclusion of bipolar. The manic phase may show itself with a characteristic of irritability as opposed to the euphoric kind of qualities we typically associate with mania. So, again, expansive or irritable mood lasting at least 1 week in addition to 3 symptoms, okay? So, again, in the DSM-5 and all the other prior diagnostic categories, there's a whole list of symptoms that you can cherry pick what the person is presenting with, and you need a certain amount of those to help conclude your diagnosis. Mixed episodes. This is the criterion I met for both manic and depressive episodes nearly every day for at least 1 week. And this is one of the basic criteria you need to meet bipolar disorder. And there's a couple of different subtypes of bipolar that I'll briefly talk about in a few minutes. Then you have the hypomanic episode. Now, hypomanic is exactly what it means. The manic behavior isn't as intense as you might see in bipolar 1, but in bipolar 2 or in what we call cyclothymia, another type of condition that has highs and lows to it, the mania doesn't have as, I'll say, damaging impact or as pronounced of an impact on the person or their life as a full manic episode. So a hypomanic episode is a distinct period of persistent, elevated, expansive, or irritable mood lasting throughout at least 4 days. For some reason, the research thought it was important to make these time frame differentiations with many different diagnoses. And they generally see that if these characteristics are less than 4 days, or the need for them to be a week or more to meet the other manic or depressive features. And it's different from usual mood and does not meet severity of manic episodes, which I already talked about. So, under depressive disorders, one of the first diagnostic conditions we look at is what we call major depressive disorder. And they can include what I read earlier about major depressive episodes. You needed 2 weeks and certain symptom patterns and at least 4 additional symptoms. Major depressive disorder, 1 or more major depressive episodes without a history of mania, mixed or hypomania, it needs to be included. A specifier, if it's only a single or recurrent episode, we need 2 or more episodes in that kind of condition. Also, to be noted, under this diagnostic area, we see up to 15% of the people passing away due to suicide. So again, along with all the diagnostic conditions we have to be concerned about and how to formulate a treatment plan, there are many complicated variables, whether from the medical arena or from the psychiatric or the substance abuse area, that make the treatment approach even that much more complicated. And obviously suicide is one of them and can be seen in any one of these different diagnostic conditions I presented to you so far tonight. Okay. Another depressive condition is called dysthymia. In the old days, where it was literally psychiatric terminology that guided many of the diagnostic conditions, this was called depressive neurosis. So the dysthymic disorder is a chronic state of depressed mood that occurs for most of the days, more days than not. Again, that's important. For most days, more days than not. For at least 2 years. So dysthymic disorder needs a continuous pattern of depressive features that extend for a 2-year period for adults. A time frame differentiation for children, the diagnostic research shows you only need 1 year to meet the criterion for dysthymic disorder. Again, specifiers, we have early onset, late onset, and then we have atypical features. But anyway, now let's talk about bipolar disorder. As I said, there's different types of bipolar. We have Bipolar One Disorder, which is a clinical course that is characterized by the occurrence of one or more manic episodes or mixed episodes. I'll say that again. Are characterized by the occurrence of one or more manic episodes or mixed episodes. With bipolar 1, the specifier must identify the most recent episode. Again, depressed, manic. You can also have a single manic episode, where only one manic episode and there is no depressive episodes. So this is the only condition that talks about bipolar 1, which usually means depression and anxiety. But sometimes people can just experience the manic phase without a depressive run of several weeks or months of depression. And if it only stands on its own with mania, it still meets the criterion for bipolar 1 disorder. You can also have the most recent episode manic and currently or most recently in a manic episode, or the most recent episode hypomanic, currently or most recently in a hypomanic episode. Or you can have the most recent episode is depressed and currently in that major depressive episode state. So most classically, bipolar 1 will give you a picture of depression and mania. Generally, the depressive conditions tend to last quite a bit longer than the manic episodes. The manic episodes may last a couple of weeks, maybe a few more than a couple weeks, and then there's amelioration. The depressive phases may also present themselves, but they can also last extensively longer than that. Also, a specifier that you need to be concerned about, and it's related to severity. You can have seasonal patterns with rapid cycling. In other words, yes, Mother Nature likes to not be forgotten, and there's seasonal patterns that can put you into one or more of these states during certain time frames of the year. Bipolar 2 disorder. Again, the essential feature here of bipolar 2 is a clinical course that is characterized by the occurrence of one or more major depressive episodes accompanied by at least one hypomanic. So again, the bipolar 2 presents itself with a hypomanic. Why is it important to distinguish? I think mainly because of its severity. The The depressive features seem to be quite similar between bipolar 1 and bipolar 2. But in the manic area, there is an important distinction between full-blown mania that can reach a point where in full-blown mania, a person can appear a state of delusional conditions where they have what we call delusions of grandeur. They think they're God or a general commanding his army or whatever else the case may be. So mania can actually reach an acute psychotic state of delusions. In hypomania, you're not going to get that level of intensity. So let me just move on here, because you know we don't have a ton of time left. As I said before, another diagnostic condition is called cyclothymia. And under cyclothymia, it includes a chronic fluctuating mood disturbance involving numerous patterns of hypomania and numerous patterns of depressive symptoms, not meeting the criterion for full depression or manic episodes, and must be at least, again, 2 years, 1 year for children. So just like Dysthymic Disorder, cyclothymia is noted to be a much more chronic condition. Again, if a person just walks into treatment for the first time and you meet the person, you might think, oh, maybe this person is a bipolar, like a hypomanic kind of bipolar. But in and of itself, it's important to make the distinction, because just like dysthymia and cyclothymia, they tend to have a much more chronic course, but may not lead to the severity of certain types of major depression or bipolar disorder. And again, I'll just identify these. They have the same patterns pretty much that we talked about before. Under mood disorders, you also have mood disorders due to general medical conditions. You also have substance-induced mood disorders. So again, same rationale, same reasoning, that all is embodied under these different diagnostic states. Now, just so you know, we got about maybe 10 minutes left, okay? Just so you can, run your clock the best way you need to at the moment. Now let's talk about outcomes related to co-occurring disorders. What we know about co-occurring disorders is that they tend to be more rapid in progression from initial use to substance dependency. There generally tends to be poor adherence to medications. There also is noted to be a decreased likelihood of treatment completion, greater rates of hospitalization. In other words, getting the person really connected with a treatment program, or getting them into a rehab, or an inpatient unit that has maybe a dual diagnosed unit on board. You see many folks with AMAs leaving the unit before their treatment program is completed. You also have noted more frequent suicidal behavior under the area of co-occurring disorders. Difficulties in social functioning. Shorter time in remission of symptoms. These are all outcome-related variables noted with OCD. Also under comorbidity of substance use and psychiatric disorders. One research project sampled 10,000 adults. Now these are adults. We were noted in that study that 13.5% had alcohol use disorder. Of those, 36.6% also had a psychiatric disorder. Another feature identified, you had 6.1% had a drug use disorder. Of those, 53.1% also had a psychiatric disorder. Then we also had 22.5% had an identified psychiatric disorder when they came in. Of those, 28.9% also had alcohol or drug use disorders. So you can see that any way you move, they're relating to each other all the time. Before I move on also, and it is addressed here a little bit, and I mentioned this before, what we're really not addressing are what we call personality disorders. Personality disorders, in the DSM we have what we call axes. We have an axis 1, 2, and 3. In the previous DSM research books, we had actually 5 axes, axes 1, 2, 3, 4, and 5. Axis 1 were your major psychiatric and substance abuse disorders. Axis 2 were identified as your personality disorders and or your mental retardation conditions, mild, moderate, severe, and profound. Then you had Axis 3, which are your medical conditions. Axis 4 are your psychiatric or your psychosocial stressors, and Axis 5 is your general level of adaptive functioning. And there's a scale from 0 to 100 that you measure how adaptive the person is functioning. The reason I just highlight that for a moment is the psychological psychiatric community appreciated the fact that all these areas need their own standalone, flashlights on them to appreciate and illuminate how important they are. And Axis 2 with the personality disorders, many of the personality disorders can encompass many of the mood and anxiety conditions we talked about here tonight, but they have their own special features. 2 personality disorders that really stand out in this, especially the substance abuse arena, is the antisocial personality disorder and the borderline personality disorder. In this situation, any antisocial and borderline on their own could take years of treatment and, going back to the drawing board 10,000 times to really get a handle on either one of these conditions. Unfortunately, we talked about motivation and insight before. For the borderline or the antisocial, it's like so buried deep into their bone that that itself takes an enormous amount of time to rise to the surface. And their sustainability in treatment is very low. So, but their presence in like co-occurring disorders that include substance abuse certainly present a much more complicated picture. So, with addiction treatment, provider estimates by psychiatric disorders. So, under addiction treatments, when you address mood disorders, you're looking at about 40%. Under anxiety disorders, you're looking at a little over 25%. Under PTSD, for folks with addictions, about 25% present with PTSD. Under the antisocial personality disorder, under addiction treatments, you're looking at about 23% who present with antisocial. With the borderline, just about the same, maybe 22%. Under severe mental illnesses that I haven't even addressed tonight, you're still looking at about 21% that can play into this ballpark. That could be schizophrenia and or other severe mental conditions. Relevance of co-occurring disorders. Substance use may be directly related to mental health issues, such as self-medication. They exacerbate one another. Intoxication withdrawal symptoms can mimic mental disorders. Substance use can trigger a mental episode, for example, substance-induced psychosis or mood disorder. Poor identification results in incomplete and inadequate treatment. I'll say that again. Poor identification results in incomplete or inadequate treatment. You have higher rates of relapse. Common co-occurring disorders. With trauma disorders, history of trauma is found in approximately 80% of the users. Opiate abuse is particularly prevalent under the PTSD and trauma areas. Anxiety disorders, generalized anxiety, panic, OCD, alcohol, marijuana, and other depressants are quite common in these conditions. With mood disorders, major depression, bipolar, common is marijuana, alcohol, and cocaine. Psychotic disorders such as schizophrenia, we see alcohol abuse being most common. Under personality disorders, the two identified here, borderline and antisocial, multiple substances. And that certainly fits the characteristics or the personality of the personality disorders. They'll do anything, any place, anywhere, anytime. Put it in front of them, whether it's driving a car 1,000,000 miles an hour, breaking rules, regulations, using whatever they want, when they want, that fits. Assessing for mental health issues. Mental health and substance use disorders can have similar overlapping symptoms. Again, mania and stimulants go hand in hand. Observable mood affect, depression, anxious, euphoric, irritable, angry, paranoid, dramatic changes across interactions can be seen. Also important to ask about when you're doing your initial assessments and repeated asking of this information is prior therapy, medications, hospitalizations, mental health hygiene, trauma histories, domestic violence. These are things that you can ask in the early stages of therapy, and there's no report by the client. 6 months later, it's like, oh yeah, and it may not be that they didn't want to tell you, just cognitively, they were at such a difficult state in the early stages of the treatment, the recall wasn't there, or the defense mechanisms were so high that there was no way you were going to be able to touch that, even if you thought you had information relevant to it. Then patience is a virtue. Timing is critical in therapy. You have to know when and where to address issues and how to approach them. Outpatient services, go from the range of brief therapy, individual to long-term individual therapy, to group models, to a combination of individual and group, to inpatient, to outpatient, to a mixture of all that during the course of folks with co-occurring disorders. Partial programs, I also forgot about that. All right. Okay, and one more interactive relationship here with substances and negative emotions. Under substances such as alcohol, the negative emotions people are dealing with is obviously the depression and anxiety, and certainly it presents itself under certain conditions such as mood disorders and anxiety disorders, benzodiazepines. Mood disorders and anxiety disorders are quite prevalent. Cocaine, amphetamine, methamphetamines, anxiety and bipolar, cannabis, marijuana, mood disorders and anxiety, opiates, heroin, prescription narcotics, mood disorders, polysubstance abuse. You have mood, anxiety, and bipolar. I think I have, as is not uncommon for me, brought a lot of information with not enough time to review it. The only thing I'll say is, under the model called cognitive therapy, I'll offer you 2 resources. There's a really good book authored in, at least give you this, by Judith Beck, and the foreword by Aaron T. Beck. Judith is Aaron Beck's daughter, and again, they run the Beck Institute for Cognitive Therapy and Research on City Ave, heading into Philadelphia. It is right across from the Philadelphia College of Osteopathic Medicine, where I did my doctorate. Actually, I also did a year's externship at the Beck Institute at one time also, right across the street. This book was authored by Guilford Press in '95, so it's certainly been a long time, but it is a really nice composite entitled Cognitive Therapy Basics and Beyond. So, if you ever want to get your hand on a starter book that can give you a good understanding. And there's a lot of nice resources at the end of this book that talk about pamphlets you can purchase at like any of the cognitive therapy institutes. And there's a number of them in New York, Philadelphia, San Francisco, Boston, London, whatever. But books that are written, books that are specifically written for practitioners like myself, or books that are written just for the general public, videos, apps, resources that are all available. Another thing is, if you ever do get involved in a little bit of cognitive behavior therapy or cognitive therapy, here's a CBT worksheet packet where you would purchase, and there's a number of different worksheets for different problem areas that are located in this book that would, in the course of therapy, be given to the patient, or actually the patient purchasing the book. And this would be a practice exercise they would do in between sessions. In many current therapy approaches, especially cognitive therapy, homework assignments are essential. The homework is the bridge between your therapy session, your life experiences, and the next therapy session. And that bridge is essential to connect the life that we live to the life we experience in therapy. And that's one of the things we realized over the years. We weren't building a good bridge between the office experience and the person's life. And tools like this help build and fortify that bridge, so there's a strong connection between what we experience in therapy and what's really going on in our life outside. It's been truly a pleasure talking with you. I deeply appreciate your time and attention. And God bless you. It's been a beautiful day. May we celebrate more beautiful days like this. And for those that just practiced their faith and had Easter as a holiday and a religious holiday, happy Easter. And for those of the Jewish faith who just completed Passover, happy Passover, and all the others that are practicing their own faiths and beliefs, bless you. Have a nice night, folks. Thanks.